بسم الله الرحمن الرحيم. أنا اسمي الدكتور محمود علاء أبو حسين، أستاذ العيون طب اسكندرية. النهاردة الجزء الثاني من محاضرة Ocular Manifestations of Systemic Disease. الجزء الأولاني كان فيه الدايابيتك changes والهايبرتنسيف changes. الجزء الثاني اللي أنا هديه لكم النهاردة عبارة عن small subjects كده، مهم إن أنتوا تبقوا عارفينها لأن هي systemic diseases كلنا بنقابلها، وكل حاجة منهم بتأثر على العين بطريقة معينة. فهنبتدي إن شاء الله. بسم الله الرحمن الرحيم. The first thing we are going to talk about today is pregnancy. Pregnancy is not like a systemic disease, it's a physiologic process, but it has some changes that can affect the eye. First of all, we have some physiologic changes, as you can see here. We have we can have decreased intraocular pressure, decreased corneal sensitivity, weakness of accommodation, dry eyes, and changes in refractive errors. Important to note that the changes in refractive errors are very prominent, and it can affect the refraction of the eye. So we don't do like surgery, refractive surgery in pregnant patients or in immediate postpartum period, because the refractive measurements are not accurate in that period. We have some pathologic conditions that can affect the eye during pregnancy. First of them is the pregnancy-induced hypertension. We call it the eclampsia or toxemia of pregnancy. All of them are synonyms. We can have in the eye decreased vision, field defects, or diplopia. Eclampsia is diagnosed when a woman with preeclampsia has seizures like convulsions, and visual changes are sign of impending seizure. So if you have a patient with visual changes and preeclampsia, it's an imminent eclampsia coming, and it's very important to handle this quickly, because it can have life-threatening events. We can have retinal vascular changes, exudative retinal detachment. Severe retinal changes are indication for pregnancy termination, so this is a very important role the ophthalmologist have with obstetrician to handle this and be in contact to save the life of the patient. The other very important thing the patient can have is diabetic retinopathy. We have to do a baseline examination in the first trimester for all pregnant diabetics. If no retinopathy is present, it is unlikely that she will develop it during pregnancy. If retinopathy is present, so we have to monitor once every trimester. The diabetic retinopathy progress in severity during pregnancy, and it can improve postpartum. It's important to note that women with gestational diabetes are not at risk for diabetic retinopathy. And why is that? Because the diabetic retinopathy usually occurs after a minimum duration of 5 years of diabetic state. So if we have a pregnant woman who has just gestational diabetes during pregnancy, she will not have diabetic retinopathy during pregnancy. Now we move on to another very important systemic disease, which is the thyroid disease. It can affect the eye. We call it thyroid eye disease, and the other name for it is Graves' disease. It is an autoimmune disease with the targets being the thyroid gland, the orbit, and the skin. Orbital inflammation and extraocular muscle enlargement with fat deposition and orbital fibrosis occurs in this disease. It has multiple stages: the acute inflammatory stage and quiescent fibrotic stage. The mechanism of thyroid eye disease is sympathetic stimulation with orbital infiltration. It can occur even with good hormonal control. So if the patient has good hormonal control, he can also have thyroid eye disease despite having good hormonal control. And smoking is a very important risk for progression and lack of treatment response. These are some of the clinical picture we can see in thyroid eye disease. It's very important to notice these changes. We can have upper and lower lid retraction, like you see here. We can have proptosis exophthalmos, which is protrusion of the eye, and we can measure it with a instrument called Hertel's exophthalmometer, like you are seeing here in this picture. And what are the complications we can see in this disease? We can have severe soft tissue involvement, corneal exposure, diplopia due to muscle restriction, and optic nerve compression. All of these are complications that can affect the patient with thyroid eye disease. What is the treatment? We must have good hormonal control. The patient should stop smoking. In mild cases, lubricants and antioxidants like selenium are sufficient. But in moderate to severe cases, we must use systemic steroids or other immunosuppressive treatment for acute inflammation. And for the fibrotic stage, we can do surgery for the symptomatic patients. And surgery must be done in the following order that's written here. We must do first orbital surgery if need be, like orbital decompression for severe proptosis and exposure and optic nerve compression. And then we can do muscle surgery, extraocular muscle surgery for diplopia. And finally, we can do lid retraction surgery for the lid. And this should be done in this sequence because each of them is affecting the other. So if we do orbital surgery, it will affect the measurements of the extraocular muscles. And if we do surgery on the extraocular muscles, it will affect the measurements of the lid retraction. So surgery must be done in this order. Next disease is multiple sclerosis. It's a neurologic disease. It is the most common demyelinating disorder of the central nervous system. It can cause optic neuritis, decreased vision, color vision affection, relative afferent pupillary defect, and field defects. And it can cause also motility disorder and diplopia due to cranial nerve affection. So as you can see, it can affect the afferent system, the optic nerve, and the efferent system, the cranial nerves of extraocular muscles. We diagnose this disease by MRI, magnetic resonance imaging, which will show demyelinating white matter in the brain stem and the brain. Another very important disease is called giant cell arteritis or temporal arteritis. It is the most common systemic arteritis, inflammation of the arteries, affecting medium-sized and large arteries, more in females and above 60 years. The symptoms of this disease is acute loss of vision, temporal pain, scalp tenderness, jaw claudication, systemic malaise with fever. The signs are firm, tender, cord-like temporal artery. We can see also anterior ischemic optic neuropathy, and the other eye gets involved very soon if not treated early. The investigations we can do is full blood count to show thrombocytosis, ESR and CRP for inflammatory markers, and temporal artery biopsy to document the histologic features. And the treatment is high-dose systemic steroids starting immediately to prevent the other eye affection. And these are the pictures we can see in giant cell arteritis. We can see cord-like tender temporal artery. And this is the histopathology we can see on temporal artery biopsy with infiltration with giant cells and granuloma formation. And this is the anterior ischemic optic neuropathy. We call it arthritic anterior ischemic optic neuropathy. And this is the field defect. It can produce like altitudinal field defect with severe affection of vision. Moving on to another very important disease, sarcoidosis. It is an inflammatory disease affecting one or more organs, but most commonly affecting the lungs, lymph nodes, and leading to a granuloma formation. The granuloma in sarcoidosis, we call it non-caseating granuloma to differentiate it from tuberculosis, which is caseating granuloma. The investigations we can do increased we have increased calcium angiotensin converting enzyme, and we can do chest X-ray to show the hilar lymphadenopathy. Histologically, you can do conjunctival or lacrimal gland biopsy showing the non-caseating granuloma. The ocular signs, it may be asymptomatic. We can have dry eye, keratoconjunctivitis sicca, anterior, intermediate, and posterior or panuveitis. We can have neurosarcoidosis affecting optic nerve or ocular motor pulses. The complications are posterior synechiae, cataract, and glaucoma formation. The treatment is topical steroids for anterior uveitis and systemic steroids and immunosuppressive drugs for posterior uveitis. And these are some of the pictures we can see in the sarcoid disease. This is chest X-ray showing hilar lymphadenopathy. These are the skin lesions. We have also inflammatory changes in the anterior chamber forming granulomatous keratic precipitates. We can have also changes in the choroid or in the retina and in the vitreous cavity with intermediate uveitis. Moving on to another disease called sickle cell anemia. It is causing intravascular sickling, hemolysis, and thrombosis, leading to arteriolar occlusion and capillary non-perfusion, affecting the RBCs, of course. We can have retinal neovascularization, vitreous hemorrhage, and tractional retinal detachment. Treatment is with laser and anti-VEGFs, antivascular endothelial growth factors, to prevent vision loss. We must do baseline evaluation and regular screening to prevent complications. And these some of the changes can occur in the retina with sickle cell disease. We have hemorrhages in the retina or pre-retinal. We have also arteriovenous connection and neovascularization of the peripheral retina with fibrotic changes, and it can cause complications in the retina. Now moving on to HIV and AIDS. We can have HIV retinopathy, which is composed of cotton wool spots and retinal hemorrhage, as you can see here. We can have CMV retinitis, cytomegalovirus retinitis, sharply demarcated retinal hemorrhages and necrosis along a retinal vessel. We can have Kaposi sarcoma, as you can see here, which can in the early stage mimic subconjunctival hemorrhage. It can occur on the lid or the conjunctiva, and it is a vascular skin malignancy. We can also have herpes zoster ophthalmicus and herpes simplex virus keratitis. And these are the changes that can occur. These are forming CMV retinitis, like an opportunistic infection in the retina. And these are the stages of CMV retinitis from mild to severe to retinal detachment. Now we can speak about syphilis, which is a very important disease, a sexually transmitted disease. It used to be very common, and nowadays it's emerging again as it can affect the eye in many ways, and it is the usual suspect for any ocular inflammation. So any ocular inflammation you can put in the differential diagnosis syphilis, because it can mimic any ocular inflammation. It can cause interstitial keratitis, uveitis, retinitis, optic neuritis with neurosyphilis. And these are some of the pictures that can occur in syphilis. We can have iris, dilated blood vessels, focal inflammation in the retina, and in the choroid we call it placoid chorioretinitis. Now moving on to some of extraocular malignancies that can affect the eye. We can have ocular metastasis in the eye affecting mostly the choroid and optic nerve. The primary is usually in the breast for females and in the lung for males, and in children the primary is mostly neuroblastoma. We can have also lymphoma either in the orbit, in the conjunctiva, or as a masquerade uveitis intraocular lymphoma. We can have childhood leukemia, which can cause retinal or subconjunctival hemorrhage. And another way the malignancy can affect the eye is the radiation. Radiation in the eye or near the eye can cause complications. The complications of radiation include dry eye, cataract, retinopathy, and optic neuropathy. Also, some patients get a treatment for malignancies like bone marrow transplantation in leukemia, and this treatment can affect the eye by what is called graft versus host disease, which can cause a conjunctival mucosal damage and symblepharon in the conjunctiva. And thank you for your attention.